All right, let's put ourselves in the hot seat. Today, we're going to run through a simulated general surgery viva exam, tackling a classic case from start to finish. Whether you're actually prepping for your boards or you just want to get a rock-solid grasp on a topic, this one's for you. Let's get started.
You know, a Viva exam is about so much more than just what you know. It's about how you think when you're under pressure. It's a test of your structure, your cool, and just like Vince Lombardi said, it really comes down to your will. Having a clear, determined game plan is everything. So here's our roadmap. We're going to break this case down into 6 parts, basically following the exact journey you'd take with a real patient, from that first handshake all the way through to post-op care. Okay, picture this. You're in the exam room. The pressure's on. I'm going to be your examiner. So take a deep breath and let's dive right in. This is your classic opening gambit. It's intentionally broad because they want to see how you structure your thoughts right from the get-go. The absolute key here is to start with a safe, systematic approach. History, then physical exam, and then investigations. Thank you. I'd begin with a comprehensive history and a really focused physical exam. My goals here are pretty simple. First, confirm the high calcium. Second, figure out the cause. And third, see if there's any organ damage or urgent symptoms that need immediate attention. So for my history, I'm going to zero in on the classic symptoms of hypercalcemia. You probably know the mnemonic: stones, bones, abdominal groans, and psychic moans. So for renal, I'm asking about kidney stones or if they're constantly thirsty and running to the bathroom. For bones, any pain, any fractures that happened a little too easily. For GI, things like constipation are super common. And honestly, one of the most important things to ask about are the neuropsychiatric symptoms. Fatigue, depression, these can be the most debilitating complaints for patients. After that, I'm going to broaden my search for other causes. I'll ask about any family history of endocrine issues, think pituitary or pancreatic tumors. That could point towards something called MEN syndromes, multiple endocrine neoplasia. I'm definitely reviewing their med list for culprits like thiazide diuretics or lithium. I'd also ask about any compressive symptoms, like a hoarse voice, which is a major red flag for nerve involvement or even a malignancy. And speaking of which, since cancer is the second most common cause of hypercalcemia, a full cancer screening history is absolutely essential. My physical exam is going to be targeted. I'm not doing a full head-to-toe here. I'm looking for signs of dehydration, which is common. I'll check their blood pressure for hypertension. For the neck, I'm doing a careful thyroid and parathyroid exam, feeling for any masses or swollen lymph nodes. Now, it's pretty rare to actually feel a mass in primary hyperparathyroidism, but you have to check. And finally, I'd test for proximal muscle weakness, another one of those classic signs. Okay, excellent. A structured history and physical exam are the absolute bedrock of a good workup. Now, let's move on to putting all that information together. This is a pure test of your foundational knowledge. A great answer here is a structured one, starting with the most common causes and then working your way down. Well, my differential is broad, but let's be realistic. Over 90% of the time, this boils down to just 2 things: primary hyperparathyroidism or malignancy. Now, malignancy can do it by either directly destroying bone or, more commonly, by releasing a substance that acts just like PTH. It's called parathyroid hormone-related peptide, or PTH-RP. After those 2 big ones, I'd consider other endocrine problems, diseases like sarcoidosis, and of course, certain medications. My plan for investigations is very stepwise. First, you have to get biochemical confirmation. I'd order a repeat serum calcium, along with an albumin level to get a corrected value, a phosphate level, and most importantly, an intact PTH level. Here's the money shot. If both the calcium and the PTH are high, that's your diagnosis of primary hyperparathyroidism. And this is a classic exam pitfall. Only after I have that biochemical diagnosis confirmed do I move on to localization studies, like a neck ultrasound or a sestamibi scan. These scans are to find the gland, not to make the diagnosis. That's a very clear, logical, diagnostic approach. You've pinpointed the problem, and you've confirmed its cause. So, now for the big question, what are you going to do about it? The examiner is now checking if you know the clinical guidelines inside and out. It's all about who gets an operation versus who we might be able to just watch and rate on. Okay, so surgery is the only definitive cure for this. The indication is a slam dunk for any patient who has symptoms, the stones, bones, groans, or moans. For patients who are asymptomatic, we follow very specific guidelines. We'd recommend surgery if they're under 50, if their calcium is significantly elevated, if their kidney function is impaired, if they have osteoporosis on a bone density scan, or if they're spilling a lot of calcium in their urine. These criteria help us find the people who are at the highest risk for future problems. Now, most of the time we're dealing with just one bad gland.
but sometimes all 4 glands are enlarged. That's called hyperplasia. For that situation, we have 2 main surgical options. The first is a subtotal parathyroidectomy. We take out 3.5 glands, leaving just a little piece behind. The other option is a total parathyroidectomy with autotransplantation. We take out all 4 glands, and then we implant a tiny piece into a muscle in the forearm. Now, why the forearm? Because if the disease ever comes back, operating on an arm is a whole lot safer than going back into a scarred-up neck.
An excellent rundown of the strategic options. Okay, let's scrub in. We're moving into the operating room. Talk me through the key steps of the procedure. All right, for a standard bilateral neck exploration, the patient is positioned with their neck extended. I'd make a transverse collar incision and raise skin flaps. After splitting the midline strop muscles, I'd mobilize one lobe of the thyroid medially. The single most important can't mess it up step is to identify and protect the recurrent laryngeal nerve. Once that nerve is safe, I can begin a systematic search to find all 4 glands, see what they look like, and then remove the diseased one or ones, making absolutely sure everything is dry before I close.
The key to this entire operation, honestly, is the anatomy you see right here. You have to think of the recurrent laryngeal nerve as your compass in the neck. The superior parathyroid gland is almost always found behind the nerve, and the inferior gland is typically in front of it. Mastering this relationship is absolutely fundamental to doing the surgery safely and successfully.
You know, the most common reason for a failed parathyroidectomy is missing a gland that's in an ectopic or abnormal location. The inferior glands, for example, can drop way down into the chest or hide inside the carotid sheath. The superior glands can get stuck between the trachea and the esophagus or even fall down behind the esophagus. A good surgeon has to know all these hiding spots and be ready to expand the search if a gland isn't right where it's supposed to be. The operation appears to have been a success, but your job is definitely not done. The hours right after surgery can be some of the most dangerous.
This is the phone call every surgeon dreads. The examiner is testing your ability to recognize and manage a life-threatening emergency. Your response has to be lightning fast and decisive.
My immediate action is to go to the patient's bedside myself, right now, no delay. I suspect a neck hematoma is compressing their airway. If I get there and I find a tense, expanding hematoma, I am not hesitating. Right there at the bedside, I will immediately open the surgical wound by cutting the sutures to decompress that hematoma. This is a life-saving maneuver. It's all about the airway. Once the airway is stable, we have to get the patient back to the operating room to find and control whatever was bleeding. So you've averted that immediate crisis, but a great surgeon is always anticipating the next challenge. For years, that overactive gland has been leaching calcium out of the skeleton. Now that the gland is gone, the bones are, well, hungry. They can start rapidly pulling calcium out of the blood, which can cause a really dangerous drop. This is known as hungry bone syndrome, and it's a critical reminder that our job isn't over when we close the skin. We have to be vigilant, monitoring and replacing calcium and vitamin D to manage this. And that right there perfectly captures the complexity of a patient's entire surgical journey.